So hello guys. So today we will discuss shock and introduction to shock. So we know that shock is very common problem in ICU. Even in emergency room, we have a number of patients with cold, calming extremities. Okay, so shock is nothing but it is combination of different hemodynamic parameters. The hemodynamic parameters it is includes like blood pressure, then clinical findings, then abnormal value. Blood pressure, systolic blood pressure less than 90 millimeters of mercury, mean arterial pressure less than 60 millimeters of mercury. Clinical findings it includes altered mentation. Most of the patients when they come in shock they are drowsy, altered mentation. Okay, urine output is decreased because of hypotension. There is decrease in renal perfusion. There is decrease in glomerular filtration rate. That's why the urine output is also decreased. Simultaneously, other organs are also hypoperfused. So abnormal lab values like serum lactate more than 4 millimole, or near about 4 millimole per liter. Then metabolic acidosis. Now, what is the basic pathophysiology? Whenever there is hypoperfusion, there is decrease in oxygen supply to peripheral tissues, there is hypoxia. The metabolism which is aerobic, it is converted to anaerobic metabolism, and the end product of anaerobic metabolism is lactic acid or lactate, and that's why there is increase in lactate and metabolic acidosis. Okay, so basic concept is that there is organ hypoperfusion. Okay, the basic concept is that there is organ hypoperfusion, and so basic therapeutic goal is to reverse this organ hypoperfusion. Okay, so basic goal is to reverse the hypoperfusion, organ hypoperfusion. Now we know that there are hemodynamic patterns associated with specific type of shocks. So there are different types of shocks. These include cardiogenic shock, then hypovolemic shock, distributive shock, obstructive shock. Okay, so and these are the parameters like cardiac index, SVR, peripheral vascular resistance, systemic vascular resistance, peripheral vascular resistance, central venous saturation, right atrial pressure, then right ventricular pressure, pulmonary artery pressure, pulmonary artery occlusion pressure. So these are the defining parameters. Okay, so if you say cardiogenic shock, what happens in cardiogenic shock? The cardiogenic shock could be because of myocardial infarction, it could be because of myocardial infarction, it could be because of cardiac tamponade. Okay, so in cardiogenic shock there is decrease in ejection fraction, the contractility of heart goes down. So that's why the cardiac index, what is cardiac index? Cardiac index is nothing but the cardiac output divided by body surface area in meter square. Okay, so in cardiogenic shock there is decrease in cardiac output. Okay, there is decrease in cardiac output means there is decrease in cardiac index. So systemic vascular resistance is high, peripheral vascular resistance is normal, central venous oxygen saturation decreased, and all pressures like right atrial pressure, right ventricular pressure, pulmonary artery pressure, pulmonary artery occlusion pressure, all these four pressures are increased because it is a failed heart and it is a congested heart. Okay, that's why all the pressures are increased. In case of hypovolemic, if you go to hypovolemic shock, what will happen? In case of hypovolemic shock, in case of hypovolemic shock, the hypovolemic shock could be because of hemorrhage, intravascular volume depletion, and the intravascular volume depletion because of any reason, vomiting, loose motions, dehydration, okay, third space losing, etc. In this case, because of hypovolemia, there is decrease in intravascular volume, the decrease in venous return, so cardiac index, cardiac output is reduced. Okay, the systemic vascular resistance, naturally the body opposes or causes vasoconstriction, so there is increase in systemic vascular resistance, the peripheral vascular resistance remains normal, and all pressures, because there is intravascular fluid depletion, because there is intravascular fluid loss because of hypovolemia, and all these pressures like right atrial pressure, right ventricular pressure, pulmonary artery pulmonary artery pressure, pulmonary artery occlusion pressure, all these pressures are reduced. So these two are opposite. You can see here these two are opposite ends. All pressures are increased in cardiogenic shock and all pressure decreased in hypovolemic shock. Now let's go to your distributive shock. So what is distributive shock? It is a septic shock. Distributive shock, for instance, the septic shock, anaphylaxis, etc. In septic shock, the basic pathophysiology, we know that because of the bacterial toxins, because of some interleukins, because of some uh, uh, other products, there is severe vasodilatation. Because of vasodilatation, there is a pulling of blood in periphery. The systemic vascular resistance mostly affected and it goes down, okay, in distributive shock. So other like cardiac index, then peripheral vascular resistance, central oxygen venous oxygen saturation, right, and other pressures like that atrial pressure, right ventricular pressure, pulmonary artery pressures, pulmonary artery occlusion pressure, all these pressures are normal or little bit decreased, okay. So basic is there is decrease in systemic vascular resistance because of vasodilatation. In case of obstructive shock, what happens? Whenever there is massive pulmonary embolism, the right and the atrial massive pulmonary embolism, pulmonary artery embolism, so there will be decrease in cardiac index obviously, and these all pressures like right atrial pressure, right ventricular pressure, and pulmonary artery occlusion, pulmonary artery pressures all are increased. So obviously the right ventricle will not be able to push blood into the pulmonary arteries. So there will be increase in right artery pressure. There will be increase in vena cava pressure. There will be increase in uh, right ventricular pressure. So this is about all types of the shocks. So we know that these are the main causes of shock, and the presentation of shock like this already we have discussed, like systolic blood pressure less than 90, then mean arterial pressure less than 65 millimeters of mercury, lactate, the end product of anaerobic metabolism, it is more than 4 millimole per liter, and the cardiac output or cardiac index is decreased. And I already told you cardiac index is nothing but cardiac output divided by body surface area in meter square. So if you go like this, so if there is reduction in cardiac output, so obviously there will be reduction in cardiac index. We have seen the formula of cardiac index, and when it is less than 2.2 per liter per minute per meter square, so cardiac index less than 2.2 liter per minute per meter square, so that is called as reduced cardiac index, okay. So this can be measured by thermodilution technique or aortic waveform assessment or transthoracic esophageal Dopplers. If what happens if this cardiac induce this cardiac index is reduced, so if it is reduced, then there are two types of shock. One is cardiogenic shock or hypovolemic shock. Or whenever this cardiac index is normal, then the patient is in septic shock. So think this. So whenever there is decrease in cardiac index, so this is it could be a cardiogenic shock or it could be a hypovolemic shock and septic shock. So ultimately we can see the different clinical features of these three types of shocks. So these are the common shocks like cardiogenic shock, hypovolemic shock, septic shock. So we can see clinical features like pulse pressure. If we see pulse pressure in cardiogenic shock, it will be obviously it will be less because the heart is pumping less blood. In hypovolemic shock there is hypovolemia, so pulse pressure will be less. But in septic shock there is vasodilatation, so pulse pressure will be on higher side, okay. So this has to be kept in mind. So diastolic pressures are decreased in all types of shock, but there is decrease in diastolic pressure to a more extent in septic shock. So extremities are obviously we know that extremities are cool, calm. So we describe it as cool, calm extremities in shock, any type of shock. But in septic shock, in sepsis, there can be warm, the extremities can be warm, okay. Sometimes extremities can be warm in case of this septic shocks. So if you see nail bed of the patient, if nail bed means capillary flow, if you want to check, so usually it is slow in case of cardiogenic shock and hypovolemic shock. As in septic shock, you have seen two features like warm extremities and the flow will be rapid comparatively, but it is not in cardiogenic or hypovolemic shock, okay. So if you see jugular venous pressure, JVP, if you measure JVP of the patient, and obviously you know that whenever there is JVP increase in JVP, it is obviously a cardiogenic shock. So right, as in hypovolemia there is less fluid, septic shocks the vessels are vasodilated, so JVP is less, right. There are some, there is, if you check IVC, there is a collapsible IVC. And in case of cardiogenic shock, we will see congested IVC. Okay. So respiratory crepitations, if you see in cardiogenic shock, there will be pulmonary edema, there will be fluid. So crepitations are usually present, which are not found in hypovolemic shock and the septic shock. S3 gallop, S3 gallop. This is a typical feature of cardiogenic shock. You can see typically in cardiogenic shock there is raised JVP, there are crepitations and S3 gallop. Okay, if you do X-ray of the patient in cardiogenic shock, there will be large heart. Pulmonary edema will be there. You can see a Bat's-Wick's appearance in the X-ray. Okay, and ultimately if you do echocardiography in cardiogenic shock, so there will be diminished contractility and ejection fraction will be reduced in cardiogenic shock. But in hypovolemic shock and septic shock, so function can be anything like obliteration. Hypovolemic shock, if you see echocardiography, there is called as typically, that is kissing ventricles. Okay, these are kissing ventricles. The ventricular walls approximate with each other. Left ventricular walls actually approximate with each other because of fluid volume loss in hypovolemia. Okay, and in case of septic shock, on echocardiography, there can be tachycardia and hyperdynamic function of the heart. Okay, so these are the clinical features of these different types of shock. So what are the miscellaneous causes of shock? So shock can be with increased cardiac output or decreased cardiac output. It is assessed by thermodilation technique or aortic waveform technique. We already discussed about it. So assess cardiac output by thermodilation, aortic or waveform assessment with transthoracic or echocardiography probe. So if you can find cardiac output or cardiac index, so if you see the high cardiac output or cardiac index is increased, means it is more than 3.5 to 4, or there can be other situation when cardiac output or cardiac index is decreased, means less than 2.2, okay, per liter per minute per meter square. So we know there are few conditions which are with high cardiac output, heart associated with high cardiac output heart failure or high cardiac output shock. So those are like package disease, it's a package disease of bone, thyroid storm, arteriovenous malformation. Okay, so these are the condition with high cardiac index. Shock with high cardiac index like package disease, thyroid storm, arteriovenous malformation. So, and the shock with low cardiac index, low cardiac index means less than 2.2 or low cardiac output. So this condition includes spinal shock, anaphylaxis, adrenal insufficiency. So in adrenal insufficiency, we know that usually there is knuckle and buccal pigmentation with hypotension. Okay, adrenal shock. Then other causes like pulmonary embolism, massive pulmonary embolism can cause shock. Then cardiac tamponade, we know cardiac tamponade acts like pressure from outside. There is one triad called as Beck's triad, that is called as Beck's triad. Beck's triad include engorged neck veins. Okay, one neck. Then other feature is muffled heart sounds, and third one is hypotension that is decreased BP. Okay, so these are the other miscellaneous causes. You can remember miscellaneous causes like with high cardiac output and low cardiac output. High cardiac output like bone disease, package disease, thyroid storm, arteriovenous malformation, and low cardiac output like spinal shock, anaphylaxis, adrenal insufficiency, pulmonary embolism, cardiac tamponade, right ventricular infarction. So this is all about basics of the shock. I think we have seen here how the shock is defined by these three parameters. Then so what are the different types of shock and what are the different parameters changes associated with these type of shocks. So again, we have seen clinical features of different types of shock like cardiogenic shock, hypovolemic shock, septic shock. In cardiogenic shock, typically we have seen there is jugular venous distension, there are crepitation because of heart failure, S3, S4 gallop is there in cardiogenic shock, chest radiograph, you see there will be bad swing appearance, there will be pulmonary edema. If you do echocardiography in this cardiogenic shock, you will have decreased ejection fraction or reduced ejection fraction, heart failure with reduced ejection fraction. In case of hypolemic shock, we will see the collapsing IVCs and ventricular walls are casing with Vitager. Okay, and ultimately we have seen the miscellaneous causes. Okay, so this was all about shock. Thank you.